So let's start the first talk of this session. Our first speaker is Dr. Aakifullah Khan. He's nuclear physician and head of IRNAM Institute of Radiotherapy and Nuclear Medicine, Peshawar. He's currently president of Pakistan Society of Nuclear Medicine. He will deliver his talk on can radioactive iodine therapy be used as a first-line option for thyroid ablation in thyrotoxicosis. Welcome, sir. Over to you, sir.
First of all, thank you to the organizers for inviting me to this esteemed forum of Pakistan Endocrine Society. And it's highly appreciative that now societies are collaborating with each other, and now we are interacting more actively than ever before. So it's an honor for PSNM to be part of the academic activity in PES conference. Well, when this conference was being organized, I was asked for a talk in this forum. So I asked them, what you want me to talk about? And because we have a lot of overlapping areas where endocrinology and nuclear medicine can collaborate with each other. So they came up with this question, and I kept the question as such without modifying it, because I thought this is the question of an endocrinologist, and we should answer the question as it is, rather than changing it into my frame of my talk. So the question has been kept as such: can radioactive iodine therapy be used as a first option for thyroid ablation in thyrotoxicosis? Before answering the question, let me introduce my organization. I also represent, apart from Pakistan Society of Nuclear Medicine, Pakistan Atomic Energy Commission, which has got 18 cancer hospitals. Now 19th is being commissioned in Gilgit. And in KP, we have got 5 hospitals which provide services in the fields of nuclear medicine, radiotherapy, and oncology. So I'll be, and I'm heading the largest of all the facilities in the province, that is Institute of Radiotherapy and Nuclear Medicine. So in this presentation, I'll be introducing you to what radioactive iodine is, or what iodine is, and how it is used in nuclear medicine, just 3 slides. And then I'll ask few questions which will answer the question being asked by the organizers. And then we will elaborate on those questions. And after that, we would come up with some more questions at the end of the session, I hope. So this is the question. And in this question, we have a term, ablation. Ablation has got different connotations in different fields. Primarily, this term came from the metallurgy, and it means removal of one substance from a surface of another substance. In medical terms, when we talk about ablation, it means removal of a tissue using surgery, laser, radio frequency, heat, chemicals, or hormones, etc. So radioactive iodine comes in that perspective when we call it ablation, removal of a tissue from a substance. So the anti-thyroid drugs cannot be compared with the radioactive iodine, because that anti-thyroid medications, they tame down the thyroid rather than ablating it. So radioactive iodine, if at all, has got to be compared in this context for ablation, then it has to be compared with the surgery. But when we talk about ablation in nuclear medicine departments, my friend Humayun Bashir would agree, we have got a very specific definition for ablation. We only use the term ablation for the removal of the remnant after the thyroid surgery. The rest of the iodine therapies are considered as radioiodine therapies. Ablation means the removal of the normal tissue after a near total thyroidectomy, when we opt for the removal of the remaining part of the thyroid that we call in technical terms in nuclear medicine, we call that ablation. So iodine, we all know about iodine. It's a everyday diet, and we take it in our diets. And you would be amazed that this iodine contains, has got 37 different isotopes. And out of these 37 different isotopes, only one is stable and all the rest are radioactive. And that stable isotope is the iodine 127. And to us, to the medical community, the important isotopes of iodine are iodine 1, 2, 3, which Humayun is being using it in various thyroid imaging services. In Pakistan, we don't use iodine 1, 2, 3 because it's very costly to be produced. It needs a cyclotron to be produced. Hopefully in IRNM, we would be having a cyclotron in the near future. So we might be able to produce it if we get a bigger cyclotron. Then iodine 124, 125. 125, we use it in RIA kits. And the most important is the iodine 131 that we would be using for therapies. Why we use iodine 131 and not the other isotopes? Because iodine has got a stronger beta decay, and the beta energies are used for the destruction of the thyroidal tissue in different scenarios. It also emits some gamma photons, so we utilize those gamma photons for the imaging purpose as well. So at the same time, the thyroid is destroyed, or the normal tissue of the thyroid in CA thyroid is being destroyed, or the metastatic deposit in a CA thyroid is destroyed by utilizing the iodine. And this iodine is incorporated into the thyroidal cells by an active transport mechanism, which is called the sodium iodine sympater protein, that pushes the iodine into the cells, that pushes don't complicate my life. It was quite comfortable. Okay, it's all right. It's just a joke. So we use the iodine in different indications. And this ablation, or what you call, or therapy of the thyrotoxicosis, is one therapy in one indication among many other indications. And one important indication that most of the surgeons refer patients for is the treatment of thyroid cancer. And in this one slide, you would be appreciating a focus of metastatic deposit. This is the normal, this is the remnant tissue or a local disease in the neck, and this is somewhere in the lung, a focal area. And you can see that this area is very hot, what we call in common terms, hot means it's containing more radiation inside it. So if it was a nuclear medicine conference, I would have gone through these slides in a flash, but it's an endocrine conference, so I have to give some explanations for some of the things. So coming again to the questions, after this, to answer the question of whether radioactive iodine can be used as a first-line treatment in the ablation of a thyroid remnant, I have to ask myself, when I'm sitting in my outpatient, some questions. And those questions are very important to be answered before deciding for some therapy options. The first of them is, what is the cause of the thyrotoxicosis? Then what is the severity of the disease? And then what are the comorbidities associated with the hyperthyroidism? And is there any structural abnormality associated or not? Do we have just a non-palpable thyroid which is hyperactive, or we have some nodularity or some goiter associated? Number 5, what are the chances of the long-term remissions in this particular patient? Number 6, What is the goal of the treatment? What do we want to achieve actually? And this is the most important question. And this goal can be the goal of the physician. At the same time, this goal can be the goal of the patient. 7, what are the response outcomes of the previous treatments? If the patient has undergone some previous treatments, so what were the responses of those treatments? And what is the will of the patient, which we ignore most of the time, and we impose our decisions on the patient. So the will of the patient is also to be asked. So the question is, can radioactive iodine be used as a first option for thyroid ablation in thyrotoxicosis? I say this is a very good question. And the scientist need not to answer correctly all the question, but at least he should raise a good question, as said by Claude Lévi-Strauss. And one humorist from Britain says that science is nothing but a series of questions that leads to more questions. So I'm asking questions in the response of the question. And the questions are still the same, and we'll be going through each question one by one. So what is the cause of thyrotoxicosis? And going into the cause of the thyrotoxicosis, you know, thyroid can be either diffusely active due to the presence of certain antibodies against the thyrotropin receptors, or activation of some areas within the thyroid which becomes autonomous, and then they produce more hormones, as is the case of a solitary toxic nodule or a toxic multinodular goiter. Then the release of the preformed hormones does occur in thyroiditis, which mimics hyperthyroidism, but it is not, and there are various causes for thyroiditis. Then somebody might have been ingesting the thyroxine from outside, or it may be produced within the body due to some tumor, which is usually the ovarian teratoma, producing some hormones, and that we call the struma ovariae. So these are the 4 major divisions. And let me quote an interesting story. I was in UK some 15 years back in the Royal Free, and I received an email from a colleague who was working in Karachi. And the colleague was quite confused about a patient. And that patient was slightly obese. The history was like that. She was a 40 years of age female. And she had hyperthyroidism, consistently high, raised T4, T3, and very low TSH. And he had done all the investigations, and he was the patient was not having any uptake in the neck, and the patient was having symptoms of like hyperthyroidism. She was denying any exogenous intake as well. And on inquiry, I said, well, I think this lady is taking some thyroxine from outside, because the tests cannot be repeatedly high. If it was at all thyroiditis, it has to come to normal someday. And then she came up with an answer that, yes, I'm only taking some diet given to me by some fitness clinic. And that diet was some shami kebab from some fitness clinic, and probably to reduce the weight, she was being given some thyroxine in that. So the etiology is very important. And if your diagnosis is not certain on simple things like T4, T3, TSH, then you can go for some other things like TRABs. And then you can do some radioactive studies as well. And you can perform ultrasonography in hyperactive cases. But we come up with 2 broad categories. One is the diffusely hyperactive gland, and the one is the focally hyperactive gland, or the focal areas of hyperactivity in the thyroid gland. The diffusely we call the Graves' disease, which is autoimmune. And the good thing about this is that 30% of the cases that they remit spontaneously. So the milder cases can remit spontaneously or may progress to even a very advanced or severe form. In the focal diseases, they don't remit spontaneously because there are certain areas that are developed within the thyroid gland. Usually this occurs in the iodine deficient areas like we have in Khyber Pakhtunkhwa, the hilly areas, and we have a lot of goiters over there. And I think there have been some genetic mutations. We have not yet worked on that because after the iodine fortification and increasing the iodine in the diet, we are not able to stop the goiters yet, and still the goiter is very common in the hilly areas, and that is the spontaneous formation of certain areas. And if you give these patients who are iodine deficient, and if you give these patients some stable iodine, they become hyperactive. So there are some evidences also. I'll be discussing that in the near future. Then the other two broad classification, one is the diffusely hyperactive and the other is the focal hyperactive. The other broad classification we do is to whether the uptake is there or not, whether iodine is being taken up in the neck or not. And in Graves' disease, toxic adenomas, multinodular goiters, trophoblastic diseases, TSH producing adenomas, and resistance to thyroid hormone, we all have increased uptake in the neck. But in various forms of thyroiditis and exogenous intake of the thyroxine, we don't see too much of a uptake in the neck. After doing these divisions, whether there is uptake or not, this is a diffuse disease and this is a focal disease, then you exclude the euthyroid hyperthyroxemia, which occurs in conditions where there is some increase in the circulating immunoglobulins or the proteins which are responsible for carrying the thyroid hormones. Actually, these carrier proteins are the instantaneous stores available to the body. Whenever there is a deficiency, rather than calling the headquarters in the serum, they can download the thyroxine. The body can download the thyroxine from the proteins. But sometimes when these proteins are increased in the body, and there are various conditions, so we need to, I don't want to go into the details of all these proteins and what are the conditions, but there are certain drugs which we come across very often in like 5-FU and perfenazine or narcotics, analgesics and amiodarons. They also cause increase in the levels of binding proteins. So usually we prefer to do a free T4 test, but it has been observed that in conditions where there is increased amount of proteins available, some increase in the free T4 is also observed. So this is called the euthyroid hyperthyroxemia. And if you exclude the euthyroid hyperthyroxemia, then you should exclude, if the TSH is not low, then you should exclude the TSH mediated hyperthyroidism. And for that, you need to do MRI of the pituitary fossa. These are some of the scans which shows, the one is showing a cold nodule, the other is a Graves' disease, a toxic multinodular goiter, hot nodule, autonomous nodule, solitary toxic nodule, what we call, and a scan where there is no uptake in the thyroid, that's called thyroiditis. So this was just to give you the visuals of the thyroid, how we look at the thyroid as a nuclear physician before deciding. The other point is we need to know what is the severity of the disease. Severity of the disease is very important to be ascertained before deciding for any treatment option. And you know, the hyperthyroidism has got a broad spectrum from an asymptomatic person to a severely symptomatic person with atrial fibrillation, with many comorbidities, and the complications related to hyperthyroidism. So severity of the disease need to be ascertained before, and subclinical need not to be treated with radioactive iodine or surgery, and it should be observed or with a mild doses of anti-thyroid drugs. Sometimes we need to look at the biochemical tests as well to ascertain the severity of the disease. But these tests may not correlate with the clinical picture. Sometimes the patient is very less symptomatic and the clinical picture. So there is a vague correlation between the thyroid hormone profile and the clinical severity of the disease. So biochemical evaluation of the disease severity, in a subclinical, we have a normal T3, T4, but a subnormal TSH concentration, and these are not the patients who should be treated with radioactive iodine. I'll be concluding after answering all these questions independently. So we are on question number 2 now. For those who have come later in the part of this presentation, we are talking about the role of radioactive iodine, and we are answering the questions, what questions we would be asking ourselves and ourselves in the OPDs, like what is the cause of the hyperthyroidism? The second question was, what is the severity of the disease? And the third question now comes, what are the comorbidities? Assessment of the comorbidities are very much neglected in the management of hyperthyroidism, and because we clinicians have gone more into tests and evidences, and we have slightly, especially in this COVID area, we do not go that close to our patients and we miss a lot of things. And I think a good history and a clinical examination would give you clues to any pulmonary, cardiac, neuromuscular, or dermatological abnormalities. Cardiac evaluation is very important in thyrotoxicosis, and the rhythm or evidences for ischemia should be sorted out, and failure should also be documented if at all there are signs of the cardiac failure, because hyperthyroidism in severe cases may be associated with the failure. The most important comorbidity in apparently healthy individual, young individual, is the Graves' orbitopathies, what we call, I don't call it ophthalmopathies. So the thyroid-related orbitopathies or thyroid eye disease, what we commonly refer to, they may be discordant with the disease. They may come sometimes earlier than the hyperthyroidism, may coexist with the hyperthyroidism and come along with the hyperthyroidism, or sometimes they may come after the hyperthyroidism. So radioactive iodine therapy is not indicated in the active moderate to severe hyperthyroidism. Otherwise, in the active orbitopathy, moderate to severe orbitopathies, they are not indicated because there are studies which suggest that it may worsen this Graves' orbitopathy. I slightly disagree to the notion because it has been evident in a study where 20 to 30% of the aggravation has been noted in the eyes. But if you give someone any other treatment, still in those patients, the worsening of orbitopathy can be seen later in the later part of the course of the disease, because the orbitopathies has got a different course and it may be slightly delayed in presentation. So that might be the reason. But as the guidelines suggest, so I think moderate to severe active diseases should not be treated with radioactive iodine. And of course, the sight-threatening Graves' orbitopathy. In other comorbidities, we should also look for some retrosternal extensions. And if patient is hyperthyroid and having retrosternal extensions, then the patient should be monitored and should be looked for the compression symptoms and the trachea. And in those cases, if possible, surgery is the best option to reduce the pressure on the trachea, because in those cases, if you give radioactive iodine, then it may cause a bit of a shortness of breath. Pulmonary neuromuscular functions and the presence or absence of peripheral edema, eye signs, and treatable edema should be looked for. Now, coming to question number 4, is there any structural abnormality in the thyroid or not? We have already taken slightly this point in the comorbidity part. Yes, structural abnormalities are very important. If somebody has got a bigger goiter, which has got nodules which are not taking up radioactive iodine, so these are the ones who should not be treated with radioactive iodine. But and as this is a picture from ATA guidelines. Nowadays, ultrasound has become more and more accurate in identifying which nodules should be picked up for radioactive for FNA. So based on these guidelines, we can select our patients who should, along with the hyperthyroidism, should be treated initially with antithyroid drugs and referred for surgery. So this is again the same slide. And the question number 5 is, what are the chances of long-term remission? And now we have got certain elements which are dictative of the long-term remission. And the nodular disease, like solitary toxic nodule, toxic multinodular goiters, patients with positive antibodies, large goiters, male gender, and they are not supposed to go into long-term remission. Number 7, what are the responses and outcomes of the previous treatments? It's very important. If you have given somebody antithyroid drugs and patient is remitting off and on, so you can go for radioactive iodine. If some patient has undergone a subtotal thyroidectomy for a multinodular goiter, we receive a lot of patients with subtotal thyroidectomy, and after that having a toxic symptoms, we come up with toxic nodules in a recurrent multinodular goiter setting, and these are the patients. And there was one case in UK a few years back, there used to be the practice of doing a partial thyroidectomy for the treatment of thyrotoxicosis. I received a patient from abroad, and she had a nodule in the thyroid, and that was intensely hot on the iodine in the pertechnetate scan. And I thought she has got a nodule. Then there was a scar on her neck, and she said that, yes, I had some treatment in UK for my hyperthyroidism, and that was in fact one lobe which was hyperactive after removal of one lobe, which was a partial thyroidectomy. Nowadays, this is not being done, and that appeared to be a solitary toxic nodule. And then coming to what is the goal of the treatment. So the goal of the treatment is very important. If you are trying to reduce the thyroid size, so you better go for surgery. If you are there to reduce the symptoms, you better go for antithyroid drugs first. And if you have to cure or ablate a hyperactive nodule, so then you can opt or a diffusely hyperactive gland. So your goal of the treatment, sometimes the patient wants conception or she is pregnant, so there you should be your goal is to preserve the pregnancy. So sometimes the patient has got symptoms which are very much related to the comorbidities, and the patient is very much restless because of the comorbidities, like pulmonary edema. If somebody has got an AF, or somebody has got a so you better not to decide for the initially for the curative or intents or for the ablative intents, rather than treat the patient's symptoms. So all these have been adequately. And the last question, what is the will of the patient? what the patient wants. And this is the most neglected question that we often miss in our clinics. You have to explain to the patient that the logistics, the benefits, the expected speed of recovery, the drawbacks, the potential side effects and costs and local availability and associated costs, and availability of the expert high volume surgeons in your area. And then if they are not available, then you can opt for other options as well. So let's conclude the discussion. If you have adequately answered the 8 questions that I put on the slides, ascertain the cause, number 1. You have ascertained the cause, you have quantitated the severity of the disease, you have identified the comorbidities, you have seen the structural abnormalities, you have predicted the chances of remission, you have a clarity of your goals, and you have recalled the responses of and the outcomes of the previous treatments, and you have asked for the will of the patient. Then you have got the answer to the question that I have been asked in the first instance. Radioiodine therapy can be indicated when there is moderate to severely hyperthyroid patient with good uptake on the scan, individuals with comorbidities and increased surgical risk, patient with previously operated recurrent toxic multinodular goiters, externally irradiated necks in the past, lack of access to high volume thyroid surgeons, contraindication to antithyroid drug usage, failure to achieve euthyroid states after the first ATD's course, and patients with periodic thyrotoxic hypokalemic paralysis, right heart failure, pulmonary hypertension, congestive heart failure, women planning pregnancy in the future more than 6 months after the treatment, and most importantly, patient developing side effects or toxicities secondary to antithyroid drugs. So, sorry. Surgery can be opted in those cases who have got symptomatic compression or large goiters more than 80 grams, relatively low uptake on the iodine, when thyroid malignancy is documented or suspected, and large thyroid nodules, especially 4 centimeters, who are non-functioning or on the scans. Antithyroid drugs are always handy before radioiodine therapy or surgery, and you have to make the patient euthyroid or near euthyroid before giving radioactive iodine therapy. So antithyroid drugs can be continued to those women who have got mild disease, small goiters, negative TRABs, who have got pregnancy, elderly with comorbidities which are increasing the surgical risk or limited life expectancy, individual in nursing homes who have got no care facilities related to their personal care, and they are unable to follow the radiation safety guidelines, patient with moderate to severe Graves' or orbitopathies, and patients who need more rapid biochemical disease control. This is just a summary which is given in the ATA guidelines. So the most important thing is discuss and do not dictate. Once the diagnosis has been made, the treating physician and the patient should discuss with each other the treatment option, and that should include all these things given on the slide. This is a last slide before my question answer session. And this is our 19th cancer hospital being built in Gilgit. And we are proud to present the 19th cancer hospital for Pakistan. Pakistan Atomic Energy Commission has done a great job in establishing a center in Gilgit. And we are going for a center in Kashmir as well. So fingers are crossed. And another one, the 20th in Narowal, is about to be completed. So thank you all of you for your patient listening. And I hope you enjoyed the questions. And I hope you must be having questions at the end of the questions. So,
sir, my name is Dr. Mazhar from Sargodha. My question is that what is the role of calcitonin in medullary thyroid cancer? Number one. And second one, if you want to diagnose nodule and you want to take help of CT scan, and we know that while doing CT scan, we use the iodinated dye. And what will be your preference in that?
We do not recommend answering to your second question first, because that relates to my specialty. So we nuclear physician, we don't like iodines too much if we are planning to give iodine, the radioactive iodine. Right. And we prefer to give the patients no contrast during the CT if it has to be done. But nowadays the thyroid nodules are very adequately visualized with the help of the ultrasound, and ultrasound is being advocated to be as a first line your structural evaluation modality. And if the patient has got a carcinoma and you have because we are talking in terms of hyperthyroidism, if you come up with a nodule which is suspicious of malignancy in the thyroid, you do an FNA and you come up with a Bethesda category 4 or 5, and you're planning for surgery, yes, you can do a CT with contrast. But if you have got a hyperthyroidism with a multinodular goiter and you don't come up with any suspicious nodules in that, you should better refrain from iodinated contrast. Regarding answer to your first question, which is not related to this talk, but calcitonin has got a diagnostic as a follow-up role in the follow-up of a medullary thyroid carcinoma, rather than as a. But if you find a very sky-high calcitonins, then the evidence is very clear that you have got medullary carcinoma thyroid at hand.
Right. My question to the forum, that if we want to treat hyperthyroidism in pregnancy, and we know that if we use numercazole or methimazole, it causes choanal atresia in infant or cutis aplasia. So what will be your choice for the treatment of hyperthyroidism in pregnant women? Number one. And second, my question is that in subacute thyroiditis, there is a elevation of T3 and T4 level and suppress TSH level. So should we treat subacute thyroiditis or hyperthyroidism, subacute hyperthyroidism? So please answer this.
Thank you very much. Actually, the session is not related to thyroxicosis in general. That was to look at the role of nuclear medicine in this condition. But since you've asked this question, if a woman is already having Graves' disease, it's important that she is stabilized well enough, and the pregnancy should be a properly planned pregnancy, and unplanned pregnancy should be avoided. So, and definitive treatment options should be discussed with her. So, rather than continuing anti-thyroid drugs, maybe she can opt for surgery or radioactive iodine well ahead of planning her conception. But if she continues to be on anti-thyroid drug, then she should plan pregnancy at a time when the disease is stable on a really low dose of carbimazole. And once she gets pregnant, and if her dose of carbimazole is less than 5 or 10 milligram per day, it can be safely stopped during pregnancy, because you can go ahead with mild hyperthyroidism during pregnancy without treating it. And in the first trimester, if she really needs anti-thyroid drug, then propylthiouracil is used to avoid all those embryopathy that is associated with carbimazole. And then after 16 weeks of gestation, she can be switched to carbimazole in really low doses. And pregnancy has an ameliorating effect on thyroxicosis. So generally, most of these women will get off their anti-thyroid drugs. The other situation would be if a woman is presenting during pregnancy with thyroxicosis, then keep in mind that gestational thyroxicosis is a very big differential to Graves' disease. And that should be kept in mind and should be properly evaluated, because gestational thyroxicosis women do not need any treatment. Thyroiditis, doctor?
Your second question about the treatment of subacute thyroiditis, where they have features of thyroxicosis. I mean, antithyroid drugs do not work and they are not indicated. In fact, should not be used at all in patients with severe thyroiditis. If the patient is symptomatic, you may give beta blockers for thyroid symptoms to be relieved. And for the thyroiditis, as said, you may have to use steroids or non-steroidal anti-inflammatory.
Assalamu alaikum. Dr. Kumar Masood here. Yes, my question is, when we treat this toxic nodules with the solitary thyroid adenoma or solitary toxic nodule with radioactive iodine treatment, about 10 to 20% do become hypothyroid. What strategies can we use to decrease this incidence of hypothyroidism?
Yeah, well, radioactive iodine therapy, your aim is not to keep the patient euthyroid. The goal of the treatment is most of the time is to make the patient hypothyroid. But आप बैठ जाइए, तफसील से जवाब दूंगा आपको, ठीक है? अगर आपके पास पेशेंट है और उसका नोड्यूल है और सॉलिटरी टॉक्सिक नोड्यूल है, सॉलिटरी टॉक्सिक नोड्यूल और ग्रेव्स डिजीज दोनों के बीच में जो कंपैरिजंस हुई हैं, तो सॉलिटरी टॉक्सिक नोड्यूल या टॉक्सिक मल्टी नोडुलर गोइटर में हाइपोथायराइडिज्म होने के चांसेस ग्रेव्स डिजीज को आयोडीन देने के हाइपोथायराइडिज्म होने के चांसेस से कम है। ग्रेव्स डिजीज चूंकि डिफ्यूज डिजीज होती है, सारे एरिया में रेडियोएक्टिव आयोडीन फैल जाती है और पूरा का पूरा थायराइड अबलेट हो जाता है बाय योर टर्मिनोलॉजीज, व्हिच वी कॉल डिस्ट्रॉय हो जाता है, ठीक है जी। लेकिन इन नोड्यूलर गोइटर्स व्हाट हैपेंस, द नोड्यूल्स accumulate the radioactive iodine and the rest of the thyroid is spared. But still there are instances we get a total reduction in the size of the nodule, but still some activity is being taken up by the rest of the thyroid and the patient do get hypothyroid. There have been efforts in the past because radioactive iodine is being used since 1940. So efforts have been made to give an optimum dose to the thyroid, but that studies have not been successful because of the reasons that the most important variable what we miss in the radioactive iodine therapy is the residence time. How much time would this radioactive entity stay in the thyroid gland? We can predict the volume, we can calculate the dose given, but we cannot accurately. For that, you need to have a longer study of 7 days before giving a radioactive material. So you have to give a very low dose of radioactive iodine. Then you have to do a specific dosimetry, which is a very cumbersome process. Even in the same patient, if you do surgery, there are chances that the patient may go hypothyroid after surgery. And most of the patients, they go hypothyroid. So still replacement therapy is the answer then. So I hope I answered your question.
Yeah, just for my endocrine community here, I mean, just sometimes pre-treatment with carbamazole or methimazole, whatever we use in our setup, that if we have treated a little bit longer with new antithyroid medications, because these toxic adenomas, then the remaining thyroid may start taking the uptake there. Because if we don't pre-treat with antithyroid medications, the likelihood that most of the uptake would go to the thyroid nodule, and the remaining thyroid, which is dormant at this time, may take a very little amount.
Yeah.
So, but what I experience in my case is that sometimes when the patient is not decisive about radioactive iodine, and we treat them symptomatic with antithyroid medications to cool them down, at that time, if the remaining thyroid has waking up, then the chances of hypothyroidism goes much.
It's a very valid explanation. There is a valid explanation, but needs substantiation with studies. And I think we should pursue your project as your proposal can be incorporated into a research study. We appreciate that. Sir.
Shall I ask a question? The usage of radioactive iodine for hyperthyroidism, there is a difference of practices in the North America and Europe and UK. The North Americans are much more aggressive in terms of giving radioactive iodine to their patients with thyrotoxicosis. They give it even to children and to ladies who have not completed their families, as contrast to what is happening in the UK or the Europe, where they do not give it to ladies who have not completed their families and avoid giving it in. Can you shed some light why this is the difference between the
Yeah,
two?
the same, the same is true with us as well. We in the north are very aggressive in this matter. The northern part of Pakistan is very aggressive in that matter. We do give radioactive iodine in slightly higher doses as well as in children and younger age group as well. Why it's the practice? Because the confidence of the people have been of those people who have been using it. For example, in children, we have come across a lot of problems in the maltreated or the undertreated or the poor compliant children who goes to the doctor for once in a while, and they have got a lot of, they get a lot of complications later on with that persistent hyperthyroidism, because the parents are not that careful. So in those circumstances, I've given very few radioactive iodine therapies in children. I remember 3 major cases. And all were more of based on the severity of the disease, the larger goiter sizes, and the socioeconomic constraints of the patients, because they were not able to follow the follow-ups in that. Regarding the differences in various parts in America, different people have got different experiences with radioactive iodine. But the experiences, I remember one study conducted in, well, why should we not be giving it in the children? For fear of few things. Like one thing is the possibility of malignancy in the coming years, because the child has to live for another 50, 60, 70, probably 100 years more. As the time period for the oncogenesis is longer, so the patient might go into some sort of a second cancer. There have been studies, a lot of studies have been supported in this context. All those children who have been irradiated with radioactive iodine as compared to those who have been irradiated with some other sources, like the accidents, like the Chernobyl survivors, when they were compared with the patients who were being treated with radioactive iodine, because radioactive iodine is like destroying the cells. Now I give you another perspective, that all those, there was a study of around 4,000 patients, if I'm not wrong, I've not brought that slides with me, of a Scandinavian country, Swedish study that was, and they compared surgery, antithyroid, and radioactive iodine. So the chances of malignancy were highest in the antithyroid group, because of the reason that TRAB is by itself a stimulating thing. So if you reduce the number of cells on which it is acting by surgery or by radiation therapy, you destroy the cells. So the chances of malignancies are reduced as such in the thyroid. As far as the rest of the body malignancies are concerned, they have found no evidence of increased incidence in those patients who have been treated in the past with radioactive iodine. We are not talking about external radiation or the radiation given for an X-ray, because the softer radiation are more notorious to produce the X-rays, or the previously a patient we were being treated with for lymphomas of the with the radiation, so they had more chances of getting a thyroid malignancies. Thank you.
Thank you very much, sir. It was an excellent and detailed talk. I hope most of your questions have been answered. Moving to the next speaker, we have Dr. Humayun Bashir. He is FCPS, FRCP, FRCPE. He has done his fellowship in pediatric nuclear medicine. He is consultant nuclear medicine at East Kent Hospital University Foundation NHS Trust, Canterbury, UK. He is a member of Board of Directors of the Asia Oceanic Federation of Nuclear Medicines and Biology. He has been past president of Pakistan Society of Nuclear Medicine. There are several publications to his credit. He will deliver his talk on molecular imaging of Pheochromocytoma, MIBG versus DOTA. Welcome.
Assalamu alaikum. First of all, thank you very much to PES for inviting me. I previously attended and presented in this hotel in another PES meeting a few years ago. Recently, I relocated back to UK after 11 years at Sheikh Hospital, and I was requested for a talk, which is indeed my pleasure and privilege to be here. Thank you very much, everybody. I'll be talking about molecular imaging of pheochromocytoma, MIBG versus DOTA. MIBG is one of those molecular tracers which has been around for almost 4 decades. After I-131 for thyroid treatment, this is the tracer which, where nuclear medicine interacts with endocrinology. Okay, pheochromocytoma has been called an imaging chameleon. It's a benign tumor, located almost 90% above the kidneys. 98% of the time it's in the abdomen, but it has certain clinical features that a risk of generating arrhythmias and cardiac situations if untreated. So a benign tumor, but has the potential to create a medical emergency for clinicians in medical specialties, and particularly endocrinology. So that is the reason it has been, and since MIBG was discovered almost 4 decades ago, it became a very good tracer to image functional aspects of this tumor. It has been called a chameleon. This is a paper from 2007, because we have certain features on CT and MR which sort of characterize the more common adenomas in the adrenals, and then we had MIBG. But yet within that group, there could be such overlap that the clinical features would still create a situation where it was always useful to have the structural imaging with a molecular tracer. So that's why MIBG, although the availability was questionable across a country like Pakistan, but it will always remain in sort of fashion. That's why most of the endocrinologists during their training years are used to it. What has changed from MIBG recently is that over the 4 decades, many other tracers were used to evaluate the functionality and the function of the adrenal tumors, and to identify PHEOs before they could actually go and actually start operating on them, because operating itself can actually lead to biopsying it is difficult. So this is a diagram which shows different radio tracers which has been used, which utilize different mechanisms for actually how to functionally evaluate these things. This is MIBG, the most famous one. Then we have got DOPA, F18 labeled. This is a PET tracer. And these are the latest ligands, which in this talk is about DOTA. Now, when we're talking about MIBG versus DOTA, the major difference is not just about 2 radiopharmaceuticals. It's about how these 2 radiopharmaceuticals, which are clinically and commercially available, are utilized. MIBG is a radio tracer which is used by, which will be imaged by a conventional gamma camera, which are available in every nuclear medicine department. That's a SPECT tracer. Previously, it used to be called gamma camera. Now they are called SPECT cameras. It's the same machine. SPECT basically means that it can take a 3D image. And almost, I think 90%, 98% cameras in Pakistan have the SPECT capability. And when we talk about DOTA, these are the PET tracers. This is positron emission tomography. There's a complete difference between those 2 technologies. The energy of the radio tracer is different. This is the gamma camera, which actually goes around the patient. The newer ones are much like that, but this is a conventional camera. This is a PET scanner, which images positron emission tomography. The energy of these radio tracers is 511, much higher, much better resolution, and much better, the chemistry and the radiopharmacy, and the complexity of creating these radiopharmaceuticals is difficult, is complex, but then the yield is much better. So these are when we talk about MIBG versus DOTA and other tracers, we talk about 2 different technologies. And just to mention, this last column over here shows that all PET scanners are hybrid. So they've got CT with it, and they've got even PET MR. First PET MR will be coming to Pakistan, I think, in the 3 to 4 years time in the Sheikh Khan Hospital in Karachi. So that's from it to start. And most of the atomic energy hospitals as well now already have SPECT CT cameras. So now you can see the radio tracer along with the CT images, and that's has added to the more accuracy of these diagnostic tests. Okay, now this is a diagram to show the difference. This is an MIBG scan. A fuzzy image. You can see these are normal uptake in the head and neck salivary glands, liver, heart, GI system, excretion through urinary bladder. This is an MIBG scan. This is a normal DOTA scan. And you can see the image is much sharper, and the distribution of the tracer is different. Here, the spleen is quite hot, more hot than the liver. These are the kidneys, adrenals on the top. Normal adrenals also show uptake. This is a very intense radio tracer in the bladder from which it's being excreted. So these and the mechanisms, this is a norepinephrine analog, this MIBG, while the DOTA, these are somatostatin receptor analogs. And so this, we have got a ligand in which the radio tracer attached, and that's the target where it's, binds on the cell surface. This is a clinic scoring system because whenever we're dealing with imaging, we'd like to quantify it in some, semi-quantitative manner, what we call normal, what we call abnormal. So this is the, scoring system, which was essentially developed for octreotide scans. But now more and more, even MIBGs have been judged on this one. There are other scoring systems as well. And the DOTA scans are also being judged on this staging system. And this actually helps. There are different scoring systems for all sort of lymphoma imaging with PET and other tracers. And this is the sort of agreement area with which the nuclear physicians and the clinicians get on the same page. So we would know what we are calling abnormal and what we are calling normal. The latest thing is that, a radio tracer or a tumor or a lesion that you can see with a radio tracer, you can also treat it with by giving a radio tracer which of high energy. Our entire previous talk was about iodine treating thyroid diseases, benign and malignant. Theranostics has become a new thing. You can see MIBG with the I123. You can treat MIBG by tagging to lutetium or MIBG 131 and 3. So the nuclear medicine has been doing theranostics for 7 decades. Now it has become more fashionable because we've got newer radio tracers and we can target more things. This is the study from 2009. This is all the radio tracers that have been used for different tumors and diseases related to neuroendocrine origin. And here in this red box, you can see octreotide, DOPA, dopamine, MIBG. These are the radio tracers which have been specifically used for pheochromocytoma. And you can see that, look, this is the sensitivity start. The most sensitive radio tracer has been PET labeled or F18 labeled DOPA, and MIBG had a lesser sensitivity. So it's basically the availability of PET tracers in clinical and commercial use, which has put MIBG at the back foot for now. That's what this talk is about. Otherwise, there was nothing else to actually image the adrenal tumors. This is a study from published in Nuclear Medicine Communication 2017, where they looked at the normal and the abnormal uptake of DOPA, the PET tracer. And they showed that the pheochromocytoma had the maximum uptake of DOPA scan as compared to all other different pathologies of the adrenal gland. And once they removed the tumor, the normal gland still took a lesser concentration of DOPA. So the PET tracer has got high sensitivity as a specificity for pheochromocytoma. This is another study where actually they directly compared the PET DOTA knock tracer with I1 3 labeled MIBG scintigraphy. It's a prospective study. It had 106 patients, and differential included 81 patients with pheo, and then he also had perigangliomas, which is essentially extra-adrenal pheo. And they also took the whole chemical profile for having these cases. And here they proved that DOTA PET-CT may be considered as the first-line investigation in patients with pheo as well as paraganglioma, especially at high risk of metastatic disease. Metastatic disease is only seen in 10%, but that's still important because you want to know before you go and remove the tumor, you would like to know that there's no spread. And DOTA PET-CT is better than MIBG. So that's basically the ground on which we are standing, that with DOTA available, it's the tracer of choice. A few examples in this study, they actually compared FDG in patients who had tumors which were negative on the dopamine scan as well as MIBG. So those MIBG and dopamine are two tracers especially focused for Pheo, but they can be negative. And in that case, FDG, which is a non-specific PET tracer, commonly used in so many malignancies. So basically what's happening when the cells are becoming, or the tumor is becoming dedifferentiated, then this FDG, which is a sort of a wild currency, which will show any highly aggressive tumor, that's where FDG becomes helpful. And in this case, you can see the MIBG scan is negative, DOPA scan was negative, and FDG scan was picking up the disease. This is really aggressive disease. So you have something in your arsenal when patient is serious and you really want to have one test to evaluate, then FDG can be is the thing to use. Now, this is the latest guidelines from the Society of Nuclear Medicine. And these are good, I'll just show you the comparative images. This is an MIBG, this is an FDG scan. This is a DOTA scan, and this is the primary tumor. This is normal gland on the other side. This is an FDOPA scan. This is also showing the positive Pheo. And on this MIBG scan, this Pheo is just showing mild uptake. So you can see that the most avid uptake is in the gallium labeled DOTA tracer, lesser in the DOPA, even less in MIBG. And since this is not an aggressive tumor, FDG scan is negative. So in this very paper, they've compared the different sensitivities of various molecular tracers as well as structural imaging. And you can see that somatostatic imaging, because this is the, it is the most latest thing in the arsenal that we have. It pushes back MIBG way back into with its sensitivity. So the tracer of the past decades was MIBG. DOPA has got the best eyes, as I showed you previously, but somatostatin, tracer, DOTA knock or DOTA, any DOTA is better than the rest. The problem with DOPA, which is very specific to Pheo, is that the biochemistry and the logistics of preparing a PET DOPA tracer is quite complex. The advantage of DOTA tracer is that it's readily available. It has been developed primarily, not just for Pheo, but for neuroendocrine tumors. So this is, we got whole theranostic module. So this is a clinically as well as commercially viable tracer. So, in Pakistan at the moment, we've got 9 PET centers. I'm not sure if all are offering DOTA scans, but they're all capable of doing that. I mean, definitely they have in Karachi, it's available in Lahore, and if is done. So we already have it in 3 different cities. So as we get more PET scan centers and scanners, we'll be available to do DOTA more as compared to DOPA. DOPA might be the best thing, but it will always remain on the edge because its usage is limited and is more complex in the radiopharmacy lab. Now, as I mentioned, metastatic Pheo, interestingly, the Pheo, there's no such thing as malignant pheochromocytoma. WHO sort of labels them as either benign, which is 90%, or it's called metastatic if it spreads, because it's metastatic just because it is at the wrong place. Otherwise, pathophysiologically, you can't differentiate between, if it's at the right place, it's a Pheo. If it's beyond its right place, it's called metastatic Pheo. So again, in this case, you can see that FDG scan, because this patient has aggressive disease. If you can see 50 lesions on FDG scans, you can see almost 100 lesions on a DOTA scan, lesser on a DOPA, and Pheo on MIBG. So this is the tracer which is most avid for Pheo as well as metastatic Pheo. And this is the comparison, and here you can see that DOTA actually shows such high sensitivity and specificity. Head and neck paragangliomas are one of the major things out, just 10%, but outside the adrenal area, this is the most common paraganglioma. And in this series, you can see this is a patient who has got bilateral sort of jugular vein tumors as well as nodes involvement. But DOPA scan actually picks this lesion in the, this actually reverse, this is actually DOTA scan, which also picked this lesion in the vertebra. So again, DOTA is most sensitive for metastatic disease as well as paraganglioma metastasis. This is actually a mistake. This should be on this side. So you see, DOTA is the most favored for head and neck paragangliomas. They actually do this. We have this flow chart how to go about it because it gets more complex. So if you're looking at pheochromocytoma imaging for diagnosis, Pheo at the top, they have to put DOPA because that's most specific for it. But Technically, I've informed you that DOPA is not available. So DOTA, you can see, is at number 2, MIBG that goes at number 3. And all other options, DOTA is at top. In paraganglioma, in metastatic, in the head and neck benign tumors. And then these are germline mutations, which workups are suggested, but it's not available in Pakistan at the moment. Pediatric, again, DOTA is the first choice. This flow chart is about therapeutics. This is theranostics. If you can see it with MIBG, you treat it with MIBG. If you see it with DOTA, you treat it with lutetium DOTA. So this is the thing. This is what we've been doing with, collectively, nuclear medicine and endocrinology has been doing, using I-131 for this purpose. Now it's expanding beyond that. This is a busy slide. I couldn't read it. Nobody should be able to read it. This is about if you start doing gene mutation into cases of Pheochromocytoma, and it does have implications because it also has implications once you get the more, mutations and you get more information about the molecular biology of the tumors. Then there's certain further differentiation when to use DOPA and DOTA, but that's a thing in process. The clinical application is still coming up. And you see there are different clusters based, and then they'll have an impact on molecular imaging. But this is something which is not available in our part of the world. Even in the rest of the world, they're looking into it. But you can just see that with more molecular imaging being available beyond MIBG, there are more specific uses to it, and we might be looking into more specific personalized medicine through this modality. So in conclusion, this is the conclusion of the latest 2019 E&M and Society of Nuclear Medicine US guideline. It says they came up with the first specific guideline on paragangliomas and PHEOs in 2012, and they say that now gallium labeled somatostatin analogs, that's actually DOTAs, are the first line of imaging. And but if it's not available, then of course MIBG, there's enough data, then that should be the molecular imaging choice. And genomics will take further into personalized medicine. Yeah, that's essentially about the topic. This is, I've just mentioned, these are certain research initiatives that we have taken in Pakistan to promote research. This is at the top is a Bashir Alawi Award for the best paper in cancer research. This is the best abstract which can be presented at the American Society. And endocrinology has got a lot of opportunities to avail these two awards for research in Pakistan, and to take all the good work that we all do in our clinics and research centers to take it to the global stage. Thank you.
Okay, as we are running short of time, we will quickly take 2 questions. If you have questions, please do raise your hand. Yes.
This is the famous Canterbury cricket ground, which actually used to have a tree on the ground, which fell in a few years ago. So that's where I'm working now. This picture I took when they were giving us orientation for the hospital in the cricket pavilion. There were quite a few Pakistani players whose pictures are installed in that pavilion. Yes, sir.
So in our setup, where I work like in an endocrine fellow, there are many cases we have been seeing the pheochromocytoma. They are biochemically proven with symptoms like hypertension, palpitation. So we do not have MIBG and the DOTA scan available. So should we use FDG PET scan in that case? Because surgeon sometimes wants to make sure that he or she does not have any metastatic lesion.
Yes, well, the issue is that now it's true that FDG is the most commonly available tracer, but if it's a solitary tumor and you've got CT and MR characterizing it, and there's a high probability that's a PHEO, and you don't suspect a metastatic, which is of course less than 10%, then if I think, because MIBG is available in Pakistan, in different, various cities, atomic energy centers can also arrange that. So it's better to go for MIBG or a DOTA. FDG, if you think that the tumor is aggressive, you have got some clinical information as well as a biochemical, then you should use it, because otherwise that could be just, it would be overkill. Firstly, it could be negative. And if it, because all these tumors are very heterogeneous. As you could see, if you have within a tumor, one particular part might be MIBG positive, one would be DOTA positive, and third part would be FDG positive. So unless you're therapeutic to see and you can make a difference, and FDG is the only tracer available, then probably, but most of the cases you'll be able to do otherwise as well. So either MIBG or DOTA.
Assalamu alaikum. I'm Oves. I'm endocrinologist. My question is that we know that MIBG can be used as a treatment option in metastatic view as well. So can this DOTA be used as a treatment option in future, or is it
No,
being used?
it can be used. Basically, now what happens is, previously you could image with MIBG and you got metastatic disease, you could treat with MIBG, right? And in Pakistan, MIBG therapy was done very a few cases as test. Now you image with DOTA, that will be gallium labeled PET tracer. If that's positive, you treat it with lutetium labeled DOTA, which is available actually. InMol is already doing it. So it's become more easy. So, you know, you have got a tracer to diagnose, and then you have got a tracer to treat it as well.
It's on it. Just one comment for those who are not from nuclear medicine fraternity. DOTA, he has been referring to repeatedly. DOTA is actually a ligand. The last part of the word is very important. Like DOTA can be used in various other combinations. So DOTA is the linkage between a radiopharmaceutical and the radioactive moiety. So DOTA is used as a linkage. So as you would have seen, but by convention, we call it DOTA, as Humayun has been telling us. So when we say DOTA Tate, DOTA Talk, DOTA Knock, so they are actually, the last part is representative of the radiopharmaceutical, which is the active part, rather than the DOTA is the in between the isotope and the chemical, which will be attaching to the receptors. Regarding to your question, I have got the experience of treating 2 patients with MIBG in our country. One was a carcinoid, and the other one was Pheochromocytoma. Both not in my center, but I was asked to go to another center in Ahmedabad. So they can be treated with MIBG, but nowadays, as Humayun mentioned, lutetium, as well as yttrium or any other thing which can be tagged with octreotide in the future. Octreotide with a good beta emitter. Nowadays, alpha emitters are now being used to treat the neuroendocrine tumors. So in the future, actinium and other things would be actinium DOTA Talk or yttrium DOTA Tate can be used for such things. So this was just to clarify a few things.
And just to conclude it, because nobody can understand it better than the endocrinologist. Since we have been using radioactive iodine for 7 decades, now there's a whole battery of things. They already come up with a treatment for prostate. You know, so you image with the prostate PSMA scan and you treat it with lutetium PSMA. So the whole radionuclide therapeutics is going out of the roof. It will very soon. I think it's already, because once we have got prostate, now they're after breast cancer and other things. So it's become the 4th pillar of cancer treatment: surgery, chemotherapy, immunotherapy, and this is the radioligand therapy. And whenever we explain to different oncologists, we tell them, please talk to the endocrinologist. They know we have been doing that with iodine for 7 decades. Thank you very much.
Thank you very much, sir, for an excellent talk. As we are running short of time, foreign speaker is already waiting for his talk. So I will have brief remarks from our chairs. Sir, Professor Najmul Islam, sir, could you please give your remark?
Yes. Dr. Aakifullah, sir, your talk was a very good, comprehensive one on thyrotoxicosis, particularly highlighting the cases where we should be going for radioactive iodine. Can't hear you. Okay, sorry for that. So that's basically, thank you very much for a comprehensive talk on this topic, where you have highlighted on the usage of radioactive iodine and which patient and when patient and how to really approach that. Thank you. It was very, and Dr. Humayun, you have given us a very good insight into the newer developments in the field of management of pheochromocytoma. So thank you very much for your talk as well.
Aisha, your remarks, please.
Thank you very much. Very enlightening talks by our both speakers. I'm sure our endocrine colleagues have benefited a lot from these talks, especially with regards to the newer nuclear imaging available and role of nuclear medicine in endocrine conditions, especially the PRRT, which is an evolving concept in Pakistan. Pleasure to have both of you here in our session, and inshallah hope to see you in future scientific sessions as well. Thank you very much.
Thank you.